We have Dr. Sheetal, who's a senior consultant cataract and refractive surgery from Netradama group of hospitals based in Bangalore. And as you saw her walking with an award, there's probably 3 to 4 or 5 awards she gets every year in national and international conferences. And kudos to her. And we are really enlightened to have her with us. And she is going to tell us on bringing out the evading risk factors, ectasia post-refractive surgery, preferred practice guidelines.
Thank you so much, ma'am. Good morning, everyone. Thanks for the invitation to participate in this wonderful session. So I'll be talking about ectasia post-refractive surgery, and we will also have a current outlook on screening and management options. So as refractive surgeons, our biggest fear is always post-operative ectasia, and this still remains one of the most significant complications of corneal refractive surgeries. Now, some of the risk factors are already known to us, such as preoperative high myopia or hyperopia, thin corneas, abnormal topography, eye rubbing, pregnancy, hormonal imbalances. However, some of the risk factors are still not known, and we will see what they could be. So there have been various studies where they have found the incidence of post-LASIK ectasia, which is anywhere from 0.02% to 0.6%. Most of these cases of ectasia that what have been published in these papers were because of faulty preoperative case selection and also inability to detect at-risk corneas. We also recently published a paper on smile ectasia and the incidence of the same from our institute. So it was 0.15%. And what we also found was that there was a 5.7% higher relative risk of ectasia in borderline eyes versus normal eyes. And so this is a very significant finding. So let us look at the current outlook on screening and management options. So various indices have been recently introduced to help a refractive surgeon detect ectatic corneas before refractive surgery, and one of this is keratoconus percentage index, or the KISA value. So basically any value between 60 to 100% is indicative of a subclinical keratoconus. Then Randleman ectasia risk scoring system is a very popular scoring system wherein they have used various parameters such as topographic patterns, residual bed thickness, age, corneal thickness, and MRSC, and it gives you a collective score of risk scoring system. And here any score more than 3 is actually a moderate risk, and anything more than that is a high risk. So this system, however, when it was verified, it was said that it can actually miss a significant proportion of patients at risk of ectasia. So it's not a foolproof scoring system. So there may be other factors that would be playing role in ectasia development. So after that came the PTA index, which is a percentage tissue altered. So basically what they say is that it is not the residual bed thickness which is important, but it is the tissue that is altered by the refractive surgery, which is actually more significant in ectasia development. And it considers the flap thickness, ablation depth, and which is added and then divided by the total corneal thickness. So a value of 40% or less is considered to be normal. Anything more than 40% they say is high risk for ectasia. Then is the index Rabinowitz-McDonald. So this also has different parameters, central K, inferior superior steepening, and SRAX. So this also can be used. Now what is we all are more familiar with this one. This is the BAD display that combines both the posterior and anterior elevations and pachymetry data to provide a 3D tomographic representation of the cornea and compares it with that of the standard the database of corneal controls and keratoconus patients. So with all these indices, we are able to pick up early keratoconus. However, there have been reports of ectasia in normal topography also. So what could be these kind of risk factors? So we need additional investigations to detect these. So integration of corneal biomechanics with pentacam is now available, and it gives us corneal Corvis biomechanical index, which is CBI. So this is based on corneal thickness profile and deformation parameters. The normal value is within 0.5, and TBI, which is tomographic biomechanical index. So this is integration of pentacam data for a combined tomographic and biomechanical analysis. Normal value is within 0.29. So let's see how we use this integration of corneal biomechanics with topography. So this is case 1, 25-year-old female. Sphere it's a small refractive error 1.75. The bad value is 1.96. So the normal is 1.65, which is considered to be normal. So this is high. CBI is normal, but TBI is also on the higher side. Normal is 0.29. So this is a borderline case wherein you would probably want to do a SMILE extra or a PRK procedure. And this is another case where 26-year-old male, moderate myopia, thin pachymetry, bad is definitely on the higher side, 2.27. CBI and TBI are also high, so here we would probably not want to do any corneal refractive procedure. So epithelial mapping is an additional tool that can help you detect early keratoconus. So this is a case where you can actually see a typical donut shape pattern of epithelium. So this can be used to actually confirm your findings of topography. Say this patient looks like a suspect topography on pentacam. It just has a high elevation values. When you do a MS39, you can actually see there's a thinning in this area over the cone, and in the mid periphery there is thickening of the epithelium. And what is also important is the stromal elevation. So if you see this stromal elevation map, there is an elevation of about plus 10 or 12 here. So so stromal topography is actually very important, where you separate the epithelium and then look at the pathology. So it can also be used to enhance specificity and avoid false positive cases. Now this patient looks like a keratoconus. Is a posterior elevation here. It's a suspect case, but when you do epithelial mapping, the epithelium is completely normal here. So there is no donut shape pattern developing here. So in this way, epithelial mapping can also help. So in terms of management, there's nothing much new. You already know in mild to moderate cases, we have to do a cross-linking to stabilize the ectatic process. And depending upon the refraction and vision of the patient, you can choose either a conservative management or surgical management. In severe cases, we have to do DALC or penetrating keratoplasty itself. Just a new thing that we have done in our institute is that we've had few cases of SMILE ectasia, and we use the SMILE tissue in the pocket and did the cross-linking, and these cases actually did well. Showing just one example wherein tissue addition was done, and you can see there's a flattening of 4.5 diopters in the steep keratometry and 1.7 diopters in the flat keratometry, and patient's vision and ectasia improved. So this is one recent update on the management.
Thank you very much.